This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 834, recorded on November 24, 2021. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Daniel, I have this COVID live update map up, and I've ranked it according to the most infections in the last day. Do you know who's on top?
The most infections in the last day. Is it Germany? Who's winning?
Yes.
Who's winning? Okay.
Yes, 73,000. And who's number two? Of course, it's us with 47,000. So many countries are popping up. How are we doing here in New York? Are they still going up?
Things are not good. And I'm going to make sure that in my update, I talk a little bit about what's happening here in New York, what's happening across the country, but then try to give some context to it. But let's jump in. We got a lot to do. Vincent, I'm hoping actually that when this drops this weekend, I don't know how the timing will work with Thanksgiving, but we may actually have people listening that don't normally listen, right? I'm thinking of like the Norman Rockwell, everyone gathered around the iPhone listening to the TWiV clinical update so they can have a bunch of stuff to discuss. And so along that note, I actually have two quotations this week. And the first one, and I know I've quoted this individual before. I actually wonder if I didn't even use this quote before, but it seems so appropriate. You can disagree without being disagreeable.
That's
and
great.
That was Ruth Bader Ginsburg. And I think that it's easy to give that advice. It's a lot harder to follow it. I will, as I'm sure people can comment who know me well. All right, but let's also, I have a poem. The road is long and winding, but we take the challenge. We rise before fear. And the more fear, the more rise we. We rise on no warranty, but our courage only. And fear seeing us rise, fear leapt away. The road is long and winding, but we take the challenge, we rise before fear. And this is Emmanuel George Safai. He was born in Rabat, which is the capital city of the island of Goza. That's in Malta. Malta is sort of a large island and then a smaller island in the northwest. But I think a lot of people, this has been a long road. I think a lot of us were ready to be off this road about 2 years ago before it even started, before we even got on this road. But here we still are on it. So let's talk about, and I'm going to jump in on the update on case numbers when we talk a little bit about children, because I want to put it in that context. So boosters for everyone, Vincent. I don't know if you heard, but the U.S. FDA amended the emergency use authorizations, the EUA, for both the Moderna and the Pfizer-BioNTech COVID-19 vaccines, authorizing use of a single booster dose for all individuals 18 years of age and older after completion of primary vaccination with any FDA authorized or approved COVID-19 vaccine. And the scientific advisors to the CDC on Friday unanimously endorsed booster shots of the mRNA vaccines for all adults. Shortly afterwards, CDC Director Raquel Walensky, MD, MPH, endorsed the advisory committee recommendations. So just to put this in context, and there is a little bit of a context here, is it's still considered that 2 shots makes you fully vaccinated if it's the mRNA vaccines. 1 dose, you are considered fully vaccinated with the J&J. J&J is a little bit easier. If you get a second shot 2 months after the first, that does appear to improve the efficacy on sort of all types of efficacies, as we've noted. Now, as far and wide confidence intervals, I'll be honest, but there's now this sort of discussion, are the mRNA vaccines really going to be 3-dose series? Will there be periodic boosters? We don't know. This is all sort of up there, but just clarifying what is being said. And now I'm going to get right into children COVID. I think around the turkey table, around this family gathering, this may be a discussion. And I'm not really sure how it got here, but I think it's very clear at this point that we didn't need to sort of go back and forth. Children are at risk of COVID. Wearing a mask is less traumatic for a child than being hospitalized. Getting a jab is certainly less traumatic and less risky than a child ending up in hospital. But where are we with numbers? So as of November 18th, almost 6.8 million children have tested positive for COVID-19 since the onset of this pandemic. So we're approaching 7 million children here in the US that have been not only infected, but actually have had a positive test. So probably quite a bit more than that. This last week, nearly 142,000 new child cases were added to the count. That's an increase of about 32% from 2 weeks ago. And we're going into the family get-together holidays here. Case numbers are climbing across the country. The interesting thing is the numbers are climbing, but hard to say this. We are down to a 7-day average of about 1,000 COVID deaths per day from a peak of 2,000 in September and our highest peak of 3,500 back in January of this year. And this is all data from the Worldometers. I think it's worth noting more people have died after vaccines were introduced in 2021 than died in all of 2020. And the peak, right, as bad as things were in the early days, that peak of 3,500 was January of this year. So sort of troubling where the numbers are. In the local New York area, talking to our urgent cares, looking at our tracking numbers, thousands of positive tests per day. But the hospitals are still, the censuses are still lower, but there are COVID wards at a lot of the hospitals. I know last week I got a number that the entire Northwell system, right, that's 22 hospitals, about 100 COVID admissions in the entire system. Remember, this was a system with thousands of COVID cases. The New York hospitals, NYP, New York Presbyterian, right, that's part of our Columbia system, less than 100 there as well. Really a different picture. Thousands and thousands of COVID positive tests, but we are doing something that is impacting the percent of those individuals that end up in hospital. All right, testing. Never miss an opportunity to test. I've been pushing hard on this. I was on the Brian Lair show, and I got a chance on Friday to give a little shout out to Microbe TV and Parasites Without Borders. So thank you, Brian. Brian was a little jealous, and I don't know, Vincent, if you can give me an update, but I was, shall I say, bragging that they listened to TWiV up there on the International Space Station. So I don't know if they still listen since Kate has come Earthside, but you'll have to let us know. But this week, the FDA approved 3 more at-home rapid antigen COVID tests. And I do want to remind everyone, this is not something you need to get emotional and upset, and an incident today with a surgeon yelling at people. Every test has false positives. Antigen tests, PCR tests. We talk about it being about 1%, right? Now, the data actually suggests that we're getting more of these positive PCR tests that are not necessarily as clinically relevant because the PCR test can stay positive for much longer. We might even be picking up something that happened a few weeks or even a few months ago. So I think that, we're starting to talk and hopefully there's a dialogue here. We need a certain allowance for calling something a false positive. If it doesn't make sense, and the first test is positive, maybe we go ahead and repeat 1 or 2 other tests. They're both negative. I think we need to have the ability to call that first test indeterminate or false positive because, sometimes we feel like we're in a police state, right? People are avoiding testing because what if they're that person on the other end of a 1% false positive and now they're isolated for 10 days, unable to work, unable to do the other things. So I'm going to share a story. This is a testing delay story. And this is from one of my friends. I've made a lot of new friends during the pandemic. This is Noah Schmuckler. I'm pronouncing that name. I'm sorry. So Noah Schmuckler. And this was a story he shared with me. A patient who was unvaccinated had an exposure. It sounded like it was a pretty compelling exposure. And we'll find out that, yes, it was very compelling. But he kept working. And about 4 days later, he started to not feel well, had symptom onset. So he went to a place, I like to say, other than a ProHealth or Riverside Urgent Care. It wasn't even a city MD, right? So keeping it all in the family here. No urgent care fell down on the job, but somebody did. Instead of taking the opportunity and getting a rapid test in this symptomatic person with a compelling exposure, they went ahead and did a PCR. This gentleman went back to the workplace, so he could be with his coworkers the week before Thanksgiving. 3 days later, he got the phone call. And Vincent, what do you think they were calling to tell him?
I think they were calling to tell him that his PCR was positive.
Yes, it was a positive test, right? So he had a positive test. Another 3 days goes by. He's still feeling sick, but now his employer wants him to go and get a test and a letter so he can get back to work. So he went at this point, got a negative antigen test. The interesting thing is the employer was aware of that pending PCR, but kept this individual working until the result came back. Now there's this pressure. We need a note to get you back. And there's a little bit to unpack here. So, because I think this is important. So likely this was an opportunity that was missed initially to get that rapid result and then pull this person out of work before they went ahead and exposed all their coworkers, possibly infected their coworkers. The week before Thanksgiving, we could sort of imagine how this is sort of a domino effect here. And the other is a timing issue. We're now about 7 days post symptom onset. The antigen test is now negative. And that's actually what we start to see 7, 8, 9, about 10 days after symptom onset, we start seeing those antigen tests turn negative. By about day 10, we could feel really confident in the unvaccinated that we're outside of that contagiousness period. That's isolation of the infected for 10 days. Maybe people who are vaccinated, that may be shorter. It may only be a couple days before, may only be 3 or 4 afterwards, maybe half of the amount. And we have sort of growing data, but still not there on the Department of Health, CDC recommendations. And I think also an important thing to throw in here, the Pareto principle, right? And this is that principle that for many outcomes, roughly 80% of consequences come from 20% of causes, the vital few, or the 80-20 rule. And Vincent, you and I have talked a little bit about the Boulder, Colorado study where, they've shown 90% of the virus was present in less than 10% of the people. So when we talk about these reproductive numbers and we say on average, one person spreads it to 3, it's really on average, 80% of people don't spread it to anyone, but 1 in 5 is spreading it to 15 others. So I expect we're going to see a bunch of these one person spreading it to 15 others around the turkey table gatherings. Now, I think we need to mention an article that's been getting the rounds on social media. Immune Correlates analysis of the mRNA 1273 COVID-19 vaccine efficacy clinical trial is published in Science. Now, the big takeaway that people are focused on is the report that vaccine recipients with post-vaccination 50% neutralizing titers of 10, 100, and 1,000 had estimated vaccine efficacies of 78%, 91%, and 96% respectively. And then they go on to say, these results help define immune marker correlates of protection and may guide approval decisions for mRNA COVID-19 vaccines and other COVID-19 vaccines. So I think this is great. I'm sort of on board with that last sentence. This is hopefully going to be something we can use at a population level as a correlate of immunity when we're looking at approval decisions for vaccines. But the takeaway on the social media seems to be a little bit different. What I'm seeing on social media is this idea, see, I can go get those antibody levels. And if they're really high, then I don't need to get vaccinated. And that seems to be why a lot of the conversations I have when people bring up their serology test, they're looking for a justification to not go ahead with a recommendation to get vaccinated. So I like to sort of think this through in real world. So if a 70-year-old with diabetes comes into me, previously had COVID and he's showing me these high antibody levels. Am I going to recommend against vaccination because of a paper like this? If a 35-year-old athlete has already gotten 3 doses of vaccine and now has a low antibody level, am I going to be recommending a 4th dose? People seem very excited about this study on social media. So, Vincent, did you have any thoughts on this?
I don't think it's very exciting because who has neutralization titers of 1,000? Maybe a month or 2 after you get your vaccine, but 6 to 8 months later, you're probably in the 10 to 100. You're gonna be infected, but you're still protected against hospitalization and death. It's not measuring the key T cells. So, I'm not impressed. I mean, I think if you wanna say it's a correlate so that you can license other vaccines without a trial, which is what you're gonna have to do going forward, that might be okay. But I think guiding treatment, as you say, guiding vaccination decisions is wrong.
Okay. All right. So, active vaccination. Never miss an opportunity to vaccinate. Vaccines, the jabs that keep you from getting sick. Now, one concern that I keep hearing, and I know I'm going to go ahead and say the anti-vaxxers. I know the anti-vaxxers have hit this area hard. The discouraging of pregnant women to go ahead and get vaccinated. Also discouraging women who are nursing to go ahead and get vaccinated, right? So we certainly have a tremendous amount of information on how the vaccines are safe to get while pregnant. And we're also seeing that the boosters are being well tolerated in this population. But another report, the report Risk for Stillbirth among Women with and Without COVID-19 at Delivery Hospitalization, United States, March 2020 through September 2021 in the MMWR. So here the authors reported on 1 million, so it's a robust 1,249,634 delivery hospitalizations, right? That's when you go in the hospital to deliver during this time period. And they noted that women that had been infected with COVID-19 were about twice as likely to lose their babies. So I think the adjusted relative risk here was 1.90. So just really just a little more evidence that getting COVID while you're pregnant is bad stuff. The vaccines are safe. They're well tolerated. The safest choice for a pregnant woman is actually to get vaccinated, not to risk getting COVID. All right, passive vaccination. A little bit exciting new news here. Remember those monoclonals for post-exposure prophylaxis and early treatment in high-risk individuals, and maybe we're even getting another option here. So this time we got data from AstraZeneca. On November 18th, we got this new data from the ongoing PROVENT and TACKLE phase 2 trials. And these trials are looking at the efficacy of the one-time intramuscular, right? It doesn't have to be IV. You can just get a shot intramuscular of the long-acting antibody cocktail combination. So the LAAB, the lab combination of tixagevimab and silgevimab. I don't know these names. These antibodies were actually derived from B cells donated by convalescent patients after SARS-CoV-2 virus. So think about the concept of convalescent plasma, but here you've actually pulled out the good stuff. The PROVENT trial is the phase 3 trial prospectively designed to evaluate this monoclonal antibody treatment for pre-exposure, right? So these are people who are concerned, may not be getting that benefit, that protection of vaccination. The idea is to give it to them ahead of time, not just sort of waiting and rushing. And at a median of 6 months of participant follow-up, 1 dose reduced the risk of developing symptomatic COVID-19 by 83%. No cases of severe COVID-19 or COVID-19 related deaths in those treated. We also heard results, the exploratory analysis of the TACKLE outpatient treatment trial, right? So this is treatment in which patients with mild to moderate COVID-19 received 1 600 milligram intramuscular dose of the combination. This reduced the risk of developing severe COVID-19 or death by 88%, right? These are still top-line results, but we have heard that the company has submitted a request to the US FDA for the emergency use authorization for prophylaxis and as well as treatment. So exciting potential tools that we might get in our box because, I know there's talk about 1 dose, 2 doses, 3 doses, 4 doses. There's a certain point if you're having trouble generating those antibodies when you may want to just give them to a person, and pretty compelling efficacy data here. All right, the period of detectable viral replication, the viral symptom phase. At this point, still the time for monitoring and monoclonals, not the time for antibiotics, not the time for steroids. Couple updates on treatment here. And this may be stuff that gets discussed around the Thanksgiving houses, events, gatherings. We have a couple new recommendations. Recommendation 24, among ambulatory patients with COVID-19, the IDSA guideline panel recommends fluvoxamine only in the context of a clinical trial. We're still not sure where that fits in. Just a reminder on MABs, also recommended for post-exposure prophylaxis. And so recommendation 16, doing these backwards, in persons exposed to COVID-19 or at high risk of progression to severe COVID-19, the IDSA guidelines suggest post-exposure treatment. So think about that. If you have one of these events, you find out that those high-risk individuals have been exposed. Not only is the science here, but the IDSA is recommending go ahead, get post-exposure prophylaxis. Don't wait until someone gets infected, ends up positive. I know there's a lot of excitement about ivermectin, right? I'm sure this will be getting discussed around the country. Also, fluvoxamine, right? We discussed what were some interesting results. But I just sort of want to say, so if you or your patient are interested in either of these therapies, a little plug here for a trial that my friend Ken Cohen is running out of University of Minnesota. If you're excited about one of these medications, all you do is you have to be between the ages of 30 and 85. You have to have a positive COVID test in the past 3 days. You have to be out of the hospital, right? This is a first week trial. The COVID Out trial is at covidout, covidout.umn.edu. And if you go there, you can enroll online. And if you complete the study, you get $400, Vincent. People are going to run out and get COVID just so they can get into this, But no, here's your chance to move science forward. Get an extra $400. You don't need to go squirt that veterinary ivermectin paste. You can actually be part of a trial, and we can really get a sense of where the role of these medicines might be. So the study is almost fully enrolled, so do not miss your chance. Not like a used car salesman. Go out today and enroll, but only if you have a positive COVID test. So this is for folks with acute COVID. All right. Here I wanted to discuss the monoclonal antibody screening score. And why am I going here? So this is one of those issues where we see someone, this is sort of directed at our clinicians, but I think it also makes sense for our non-clinician audience. Someone has been vaccinated and now they test positive for COVID. Should you worry about them? Is there any way to risk stratify what is going to happen here? So this is a scoring system that was developed out at the Mayo Clinic. And I'm going to, again, make my colleague and friend Ben Wygand famous by mentioning him, as this came up in a recent call. He shot me an email, and then we ended up discussing it. So let me just quote from the email. Close friend, fully vaccinated, just contracted COVID-19, fever, cough, pain, 3 days out, already started on prednisone, a Z-Pack, pain meds. What is the window that we should be worried about him feeling better? Any suggestions? So I, of course, immediately responded, Ben, give me a call. So one of the first things that we discussed was stopping the prednisone and the Z-Pack, right? As we've talked about before, that prednisone is going to increase this gentleman's chance of ending up in hospital about sixfold, even going to increase his chance of mortality. No steroids during the first week. Z-Pack, not helpful, potentially harmful. But then I went through with Ben. I said, well, let's talk about whether or not your friend is really at risk of ending up in hospital. Is this one of these young athletes, ideal body weight in their 30s, vaccinated, that we're not worried about, or there's some other features? So on our last episode, we discussed the publication Monoclonal Antibody Treatment of Breakthrough COVID-19 in Fully Vaccinated Individuals with High-Risk Comorbidities. And this was actually that study where they were looking at these scores, the mass scores, and then they actually, if you go through the data, you can get what percent of these individuals with different scores ended up in hospital. So let's go through. How do you get points? You do not want points. This is like golf. The less points, the better. If your age is greater than 65, equal to or greater than 65, that's 2 points right up front. If you have diabetes, 2 points. Chronic kidney disease, 3 points. Immunosuppressed status, so you're immunocompromised, you're on immunocompromising medicines, 3 points right there. Chronic respiratory disease in an individual 55 and older, 2 points. Cardiovascular disease, 2 points. The only features that only give you 1 point is that BMI greater than or equal to 35, that's 1 point, or hypertension in a patient greater than 55, that's a point. Now, the folks that have a score of 0, that's going to be only a 2% of those patients ended up in hospital. That's actually a little higher than most people would think, right? 2%. Once you get up to a score of 2, you already have a risk of ending up in hospital of 7%. Once you get up to 3, that's 12%. And once you get up to 4 or higher, that's 30%. So if you have an individual, and we'll go back to this individual that Ben told me about, when we started talking, we realized that this individual was a little older, had diabetes, had an elevated BMI. So just the elevated BMI and diabetes alone, we were already at 3 points before we started talking about age. So people who are vaccinated, who get infected, if they have any of these features, there still is a solid chance they may end up in hospital. So we want to think about ways that we might intervene and reduce that risk. And we certainly want to avoid any interventions that would increase that risk. All right. Do you have any comments there, Vincent?
I think that's a great idea, right? But apparently your colleague didn't know about it.
Yeah, no, I think it's tough, and I think that So I think it's nice that we get this information out. So hopefully he's going to listen to TWiV, and he'll start mass scoring, and that'll help everyone. So the other thing that I think is really exciting here, right, is that a few days after this episode drops, so next Tuesday, the 30th, we're expecting the EUA for Thor's hammer, molnupiravir. We already know that there's distributed medicine throughout the country, but we also got some advice recently from the European Medicines Agency, the EMA, and I think it was important. I sort of looked through their workflow regarding this medicine. One of the issues is we anticipate that the EUA will discourage us from treating pregnant women and children, right? So think about this in your workflow. If you have a woman of childbearing age, we're going to want a negative pregnancy test, and we're also going to want to advise them, not to get pregnant during the course of treatment. It's only 5 days, so I think really think about in your workflow. If you've got a woman of childbearing age that you're considering treating with this medicine, not only do you want that COVID test, but you also need a workflow that's going to get you that negative pregnancy test as well. So when you go and get those Binex nows, go get some pregnancy tests as well. All right. There continues to be interest in whether inhaled steroids might be helpful during that first week, right? So the original investigation efficacy of inhaled cyclosinide for outpatient treatment of adolescents and adults with symptomatic COVID-19. A randomized clinical trial was published in JAMA Internal Medicine. Now, I've seen different headlines on this study. So this was a phase 3 multi-center, double-blind, randomized clinical trial conducted at 10 centers throughout the U.S. It assessed the safety and efficacy of this inhaled steroid using a metered dose inhaler for treating non-hospitalized patients with symptomatic COVID-19 during that first week, right? So this is an inhaler, a steroid inhaler that we use for treatment of asthma, for instance. Now, the primary endpoint was time to alleviation of all COVID-19 related symptoms. So cough, dyspnea, chills, feeling feverish, repeatedly shaking with chills, muscle pain, headache, sore throat, new loss of taste or smell by day 30. So kind of a high bar. Basically, you had to be all better. And the idea was that the inhaled steroid, was going to increase that. There was a secondary endpoint, which we'll talk about, which was ending up in the ER or being admitted to the hospital due to COVID-19. So basically, the median time to alleviation of all COVID-19 related symptoms was 19 in the treatment arm, 19 in the placebo arm. no significant difference. Now, as far as secondary endpoints, they did report that participants treated had fewer subsequent ER visits or hospital admissions. Ultimately, we ended up with very low numbers. They did an intention to treat analysis. They lost about 10% of folks to follow-up. And with small numbers, it's hard to know the impact there. But remember, that's a secondary analysis. So I've seen headlines here, failed to impact, the primary endpoint, but I've also seen some interest in maybe this can have some benefit. So ongoing study, we're not ready to tell people to run out, recommend that at this point. Also wanted to bring up at this point, I think this is something that from a public health standpoint is really important, maybe sort of a call to arms, write your congressman type thing. This is the issue of telehealth. We're actually in danger of losing the ability to offer telehealth throughout the country. A lot of states are going back to business as normal and limiting access to telehealth to only patients who are physically in your same state where you're seeing them. So the open access paper, Comparative Effectiveness of an Automated Text Messaging Service for Monitoring COVID-19 at Home, was published in the Annals of Internal Medicine. So here the authors reported the results of a retrospective cohort analysis of a program, it's run out of UPenn, where community-dwelling adults with COVID-19 were enrolled in an automated remote monitoring service with twice daily automated text message check-ins with an option to report worsening symptoms at any time. And if there were escalations, these were managed 24 hours a day, 7 days a week by telemedicine clinicians. And they reported at 30 days, so this is all you're doing is basically giving them access in case they have escalation, there was a 68% reduction in the risk of death just by having access to this telehealth monitoring. So pretty impressive when you think about, all the other things we can and can't offer. All right, so let's go right to the end here. So what about PASC for those infected post-vaccination, right? So I've been trying to keep my eye on this, what we're seeing. And there was a preprint that was posted. So this is a preprint, hasn't sort of gone through the full review process, but long COVID after breakthrough COVID, the post-acute sequelae of breakthrough COVID-19. So the authors used the VA system data. They identified 16,035 vaccinated people that got infected post-vaccination, and then they, as a control, had 3,569,525 who did not have an identified COVID-19 infection post-vaccination. We saw an overall rate of infection post-vaccination of about 7 per 1,000 persons at 6 months, right? So a small number, that's very encouraging. But they did find in this cohort that they were seeing a small but statistically significant increase of having at least one post-acute sequelae. What I thought was very interesting was they also analyzed the risk of PASC following infection in vaccinated versus infection in the unvaccinated. Similar to other studies, they again reported a lower risk of PASC following infection in the vaccinated versus infection in the unvaccinated. So good and bad here. Good. Vaccination reduces one risk of even, say that one more time, good that vaccination reduces one's risk of even getting infected. Good that then this is a smaller number that might get infected than a less likely to end up with post-acute sequelae of COVID, but bad. But there does still, at least in this study, appear to be a small but real risk of getting PASC even in the vaccinated. All right. No one is safe until everyone is safe. This last week was the American Society of Tropical Medicine and Hygiene annual meeting. It was virtual, which, not as exciting as getting to be there and see a lot of my friends and colleagues. So hoping next year. But I expect many listening to this with the family over the holidays will be waiting for me to talk about ivermectin. I already mentioned it once. And there was the results of a pilot trial were presented at the American Society of Tropical Medicine and Hygiene showing that ivermectin-treated bird feeders were associated with a reduction in infectious mosquito days for Culex mosquitoes, which are involved in West Nile virus transmission. Still lots to do before we broadly recommend putting in all the bird feeders. But, people have that horse paste. And I had a patient yesterday. It was really funny. We were talking about this, and she had the horse paste at home. She had purchased it, but she was hesitant to take it. I was not encouraging her to take it, but she was hesitant to take it because she was musing about how it might taste. But this might be a place for you to put that ivermectin paste in the bird feeders. All right, Vincent.
I think that's fine. I don't have a problem with mosquitoes and ivermectin, right?
Okay.
But if it's a winter, they're not going to have any anyway, right? Here
Yeah,
in the
I
Northeast.
mean, this is the time to do a study, right? You put your ivermectin in the bird feeders, and I'm gonna predict that by the end of December, January, there'll be no mosquitoes.
I think you'll be right, Daniel.
Okay. Who says you can't predict the future?
Time for some email questions for Daniel. You can send yours to daniel@microbe.tv. Mary writes, at the beginning of the last episode, you mentioned you were going to talk about dogs, but you didn't. I've been concerned about my puppy. I've been taking to obedience class and has close contact with 6 to 9 other puppies. Masks are needed, but most owners don't wear them. I'm wondering if the positive impact of socialization outweighs the risk of the dog contracting COVID. So should I not be taking my puppy out in public?
So take your puppies out in public. Yeah, what I didn't mention last time, which was sort of on my radar, was a report that they have seen about a tenfold increase in myocarditis in dogs. So it actually looks like dogs can end up developing myocarditis when they get infected with COVID. So a little bit disturbing. And I don't know if anyone read the recent stuff about the minks, where it looks like when minks get infected, 2-3 months later, they all get infected again. So unfortunately, those people who keep musing about herd immunity and COVID going away. I mean, COVID's in the dogs, it's in the cats, it's in the deer, it's in the mink, and unfortunately, that's an issue. Now, people may know I'm involved with canine companions, and we help with the service dogs. And we had a dog recently who grew up with an older couple, the puppy raising for the first 18 months, and she got to hang out with us for a little while, learning to socialize with other dogs and other people. So, during those puppy years, it's months actually, during the puppy months, it's really critical to get those dogs out there learning to socialize. So I'm going to encourage you to get your dogs out there.
So Danielle is in Germany, where case numbers are exploding and the need for good information is increasing. I'm a bit confused about the test. Dr. Alice Howarth explained in an article why she thinks a positive lateral flow should be seen as for sure positive. Here in Germany, the official stance seemed to be that these tests are only good to tell you you're negative, and only a PCR-confirmed infection can be real. And on the other hand, Christian Drosten put out on Twitter today that if you have been vaccinated, lateral flow tests are unreliable. What does this all mean? Am I doing the wrong thing? But I'm double vaccinated. I'm wearing a mask in public. Is that too risky? Can you clear this up?
Okay, certainly. Yeah, so I talk about tests every week, right? Because tests are a little bit challenging. Previously, medical professionals, you went through training, you learned how to interpret these, but now suddenly the public is told that you can fix your own car, so to speak. The big thing about testing is the pre-test probability. So going into it, you ask the question, like we had that scenario, this person had an exposure to someone with COVID. Now they've got symptoms 4 days later. The timing's right. The symptoms are compelling. We're thinking they're probably positive. If you then get a positive test, and whether it's a PCR or a lateral flow test, if it's positive, I think that sort of puts it all together. If it's negative, you're going to say, boy, my preclinical probability was really high. Not sure it makes sense. I'm going to probably have to repeat that test. You repeat it the next day. If it still doesn't make sense, you may even do it a third time. Usually we're getting the answer we need with 2 tests. So the other would be I would say the issue that we had in the scenario we talked about before, where that PCR was negative, didn't make sense, and it was the antigen test that was the first way we picked it up. The other is this issue that you bring up, and Dr. Drosten, maybe he'll come back on. He's got a big following. are things a little bit different in the vaccinated? And they are a little bit different. Not only have we seen studies where that period of the ability to detect virus is shorter, right? So we're seeing a shorter period of time that the PCR tests are positive. We're also seeing a shorter period of time when the antigen tests are positive, right? If you look at that Barnes-Table thing, a lot of those folks with PCR tests actually had negative antigen tests. So some folks post-vaccination, even though a PCR might be positive, they might end up with a really low level of genetic material before their immune system is able to put that out, particularly if it's close to vaccination. So yeah, you're getting different information, and I think sometimes it can get a little complicated to sort it out. But there tends to be a really good association between those positive antigen tests and someone being contagious. Really good association between a negative antigen test and someone not being contagious. But yeah, it gets a little tricky. And if you're not sure, reach out to that helpful medical professional, which I think in Germany is maybe free, part of your public health plan.
And finally, Rob writes, I have a friend who, and he puts friend in quotes, who was reluctant to get vaccinated, but did last month. He then presumably got COVID, lost taste and smell and other respiratory symptoms a week later. This friend is a bodybuilder, phenomenal shape, multiple hours in the gym every day. Apparently, he was taking steroids during the vaccination and infection periods, not Dex, the illegal injectable kind. He first tried to blame the vaccine, but I told him he was an idiot and explained the whole steroids suppress your immune system thing. His symptoms lingered for a week. Then he finally stopped taking the product. Symptoms went away. He then noticed some spontaneous heart rhythm problems, getting very slow, stopping for a second, then beating quickly. Got several EKGs, which were fine because there was no arrhythmia during the test. He said he never experiences the issues when working out. It seems too coincidental for this not to be related. Just wondering if you experienced anything similar or have any suggestions.
Yeah, no. So this brings up several important topics. So I'm going to hit them. One is not all steroids are the same, right? There's different types of steroids. There's steroids that actually affect the muscle, and those are the bodybuilding steroids. Those have different effects on the system than the mineral corticoids, the glucocorticoids that we're often using to calm down the immune system. So not all steroids are the same. These are different steroids, but not great, not encouraging anyone to be using illegal steroids for bodybuilding. There's a lot of negative impacts there. The other is this issue, as you describe, and comes up about myocarditis, arrhythmias, cardiac impacts. They are certainly much more common in infection than after the vaccination. So I think, unfortunately, this gentleman, when he got that COVID infection, had the probably cardiac issues associated with COVID. So one of those reasons why even someone who's young and healthy wants to get vaccinated, because the risks of vaccination are so small compared to the risks of infection with COVID. Speaking of a bodybuilder, I just was on a telehealth visit yesterday with the gentleman that I took care of in the hospital for 2 weeks. Really fit, bodybuilder, who had actually felt, boy, I'm so fit, healthy, ideal body weight, I don't need to get vaccinated. This individual ended up on high flow nasal cannula, almost didn't make it through the hospital stay. So
that's COVID-19 clinical update number 90 with Dr. Daniel Griffin. Thank you, Daniel, and have a great Thanksgiving.
Oh, thank you. And everyone, be safe.